Good morning. My name is Dawn Heckler, and I am a certified nurse midwife student at UNLV. And my quality improvement study is on the importance of hemorrhage risk assessment tools, postpartum hemorrhage carts, and med kits in the hospital setting. For introduction, postpartum hemorrhage is the main cause of maternal mortality worldwide, and in the United States, it causes nearly 11% of pregnancy-related deaths. A postpartum hemorrhage is classified in stages. Stage 0 is our normal delivery, blood loss, what's expected. Stage 1 is greater than or equal to 1,000 mLs of blood loss in vaginal or C-sections. Stage 2 is greater than 1,500 mLs of blood loss, and stage 3 is greater than 1,500 mLs, and we're either giving blood products or activating a massive transfusion protocol. And as stated, we're going to be talking about postpartum hemorrhage carts, med kits, and a hemorrhage risk assessment tool. In a study done by Kogut in 2021, stated that the average time to collect supplies and medications for postpartum hemorrhage was 11 minutes and 5 seconds. When the staff was supplied with the PPH cart, which is our intervention 1, the time decreased to 4 minutes, and in addition to having bundled medications in the Pyxis, which is intervention 2, the time was further decreased to 2 minutes and 4 seconds. So having a hemorrhage cart and medications readily available to patients, especially those with a high hemorrhage risk, along with your clearly defined protocols, can save lives. As I stated, postpartum hemorrhage is the leading cause of maternal mortality in the United States, and timely treatment is imperative. Delay in treatment can lead to significant blood loss and increased morbidity and mortality. And supplies and medications essential for treating your postpartum hemorrhages are typically not located in close proximity to the hemorrhaging patients, which could lead to inefficiency and delay in response. So a good rule of thumb is, based on your hemorrhage risk assessment, if your patient is a high risk, to have the cart readily available, usually outside the room or inside the room, and then your med kit, your medications in the room with you at the time of delivery. For local context, we're going to be using the hospital that I work in, which is Centennial Hills Hospital here in Las Vegas. It's a 12-bed level 3 labor and delivery unit with 35-bed postpartum. We have an 8-bed antepartum unit, a 4-bed triage here on the floor in labor and delivery, 2 OR suites, 24-hour in-house laborist, which is an OBGYN that can do deliveries, either vaginal or C-section, 24-hour anesthesiologists, and we have surgical techs each shift. We average about 160 to 200 deliveries per month. The purpose of the study is prevention and treatment and recognition of postpartum hemorrhage. Our questions are: will education of the nurses on the use of postpartum hemorrhage carts and standardized hemorrhage risk assessment tool help to decrease our rates? Does practicing mock codes increase the management of a postpartum hemorrhage? And does having a postpartum hemorrhage cart and or med kit save time in a postpartum hemorrhage? Objectives are across the board training for our nurses for better management of a postpartum hemorrhage. So during our literature review, found that effective postpartum treatment is initiated sooner and ongoing blood loss should be reduced, which would directly affect the results of our maternal morbidity and mortality. Found that PPH carts and kits are inexpensive to provide. We also will talk about etiology of our 4 T's: tone, trauma, thrombin, and tissue, which I'll talk about in another slide here. This is our hemorrhage risk assessment tool. Should be done on every patient admitted to labor and delivery. We have our low risk, moderate risk, and high risk factors. Low risk is things like single pregnancy, less than 4 vaginal deliveries. Our moderate risk are multiple gestations, so are we having twins, triplets, greater than 4 deliveries, vaginal deliveries, and if they have a prior postpartum hemorrhage. And then our high risk is things like placenta previa, placenta accreta, what their H&H shows, if they have active bleeding on admission, And then the bottom part of this is factors that happen during labor. So this is something that we're continuously monitoring throughout the admission, throughout labor. Do they have a prolonged second stage? Are they pushing for 3 or 4 hours? Prolonged oxytocin use? Are we using magnesium sulfate during labor? Do they have retained placenta? Things like that that we need to watch out for. This is just a slide for our 4 T's here. Tone, trauma, tissue, and thrombin. So tone is uterine atony. This is where we're having what we call a boggy uterus. This is where we're doing our fundal rubs and trying to get that uterus firmed up. That constitutes 70% of our postpartum hemorrhages. Trauma is any lacerations, hematomas, anything like that. Tissue is retained placenta usually, and then thrombin is our coagulopathies. This is active management during the 3rd stage of labor for the 4 T's. So for tone, we're giving our medications, we're doing our fundal rubs. This is where our med kits come in handy. Trauma, we're suturing lacerations, we're draining hematomas, anything like that. Tissue is we're getting the placenta out, either manual extraction of a placenta. They have tools to use for a curettage to help scrape that uterus to get that placenta out. And then thrombin is our blood not clotting. This is another medication that we can use called TXA that we can give during this time frame. So this is an example of a postpartum hemorrhage cart and a med kit that we could find on the floors. In the cart, it has a scale. We want to weigh all of our blood loss, and remembering that 1 ml equals 1 gram. We always want to do what we call a QBL, qualitative blood loss. In these carts, you can find stocked IV start kits. You can find all of your tubing, your syringes, needles, lab draw kits, fluids, manual blood pressures, Foley's, uterine tamponades, vaginal packing, anything that you can think of would be in this cart. And then in your med kit, again, we would have anything that we could think of. We would have our IV or IM oxytocin, our Methergin, Hemabate, Cytotec. Those are our 4 main medications that we use. We also use TXA, which is IV piggyback. You would have all of that available in one spot in the Pyxis fridge, or some of these carts do have a fridge attached to them that you can pull from. So during the literature review, strengths that I found are to have clear evidence that training nurses on treatment and prevention of a postpartum hemorrhage leads to better outcomes. Gaps that we may see are implementing training in the hospital setting if it's not already there. We know that can sometimes take time to implement these processes. The method that I would be using is a PDSA model. So our plan is to create and implement a hemorrhage risk assessment tool, which we saw, and then research and provide stocked postpartum hemorrhage carts and med kits, and to create your standing orders for a massive transfusion protocol and postpartum hemorrhage. We do need to train the staff on how to recognize a postpartum hemorrhage and how to act during one. You can conduct mock drills and codes throughout the day, during night shift, day shift, whatever the manager decides. We should have our nurses become familiar with the postpartum hemorrhage cart, what's in it, where it's located, how to use it, stuff like that. We also want to analyze our postpartum hemorrhage rates to track effectiveness of the policies and use of the carts and the hemorrhage risk assessment tool. And then to act on, we would modify any changes needed. Do we need more training? Do we need more things stocked? What does work? What does not work in the postpartum hemorrhage cart? Things like that. As time goes on, you see what works, what doesn't. Again, our setting is the labor and delivery unit on at Centennial Hills. Participants are inpatient staff, nursing, and our patients. Interventions would be training our nurses on how to use the carts, what's in the carts, where to find everything in the cart, and then using our standardized risk assessment tool. We would also need to make sure that other staff in the hospital is trained on the massive transfusion protocol, lab, pharmacy, RT, anything like that, that would come to help if needed. We use LMS training, which is computerized. We can do mock codes, which can happen at any time. You kind of want to surprise the nurses with these mock codes, and then attending training like skills and drills at least once a year. It could be quarterly, every 6 months, whatever the management decides is best for their nursing staff. And then for data collection would be the number of postpartum hemorrhages occurring during the number of deliveries. We would track it monthly, and then you could track it at the end of the year. For data analysis, we would compare our pre-intervention and post-intervention data. We use MIDAS, which is a hospital-wide incidence tool that we would put our postpartum hemorrhages into, collect that information. We could do chart audits to see if the hemorrhage risk assessment tool was completed at the time of admission and before birth, and how that was utilized. If they were a high risk on this assessment, did the nurse have the medications at bedside? Did they do all of the appropriate interventions to try to control that postpartum hemorrhage? Any ethical considerations? We don't really have any. You can get consent from the patient, from the nurses, but there's really no ethical considerations for this. And then implications, we would implement our hemorrhage risk assessment tool on every admission, implement the use of your med carts, your med kits, both in labor and delivery and postpartum. Postpartum hemorrhages can happen at any time after delivery. It could happen minutes after, hours, days, up to weeks, up to 6 to 8 weeks after delivery. A postpartum hemorrhage can happen. So it's something that you also want to educate your nurses on for discharge purposes for your patients. And our policy would be developing a hospital policy for your postpartum hemorrhage policy and a massive transfusion protocol, and to see if any of those need tweaked. Just make sure that everybody knows where to find them and what is contained in those policies. This is my references. I would like to thank you for listening, and I hope you guys learned something. Thank you.